Q&A. If you have any Qs, I will give the As. You do the Qs, I'll do the As. How's that sound? Right, so today, 5th of January, 2021, the New Year lockdown was announced yesterday, and I think that will obviously be a hot topic, which I am happy to discuss, and leads me to my first question, which is, during this national lockdown, Jackie's here, nice to see you, can I still book a face-to-face consultation? And that's the question on everyone's lips, isn't it? So what's the answer to that question? The short answer is yes, you can. The situation with this lockdown is different to the lockdown in March, because the lockdown in March, we were just, if you can imagine, can you remember February? Do you remember February when we were sort of walking in the street and, like, you know, when someone won in a game show, they give them a hug? Do you remember those times? I mean, I love Antiques Roadship, and whenever they do a deal, they shake the hands, and I'm like, oh my God, that must have been shot a while ago. Back in the day, Donna is in the house. Big up yourself, Donna. So anyway, yeah, so back in March, when the last lockdown happened, we were just willy-nilly going close to each other and giving each other's hugs and goodness knows what. So yes, we did close and stop face-to-face consultations back in March. However, when we opened in July, I think it was, things were significantly different, and things have moved on significantly. And if you look at certainly the way we treat people in my clinic now compared to how we treated you in February, it's significantly different, both good and bad. I mean, it's good, obviously good, because it's safer. We're all wearing PPE, we're distancing, we're only allowing one person in the clinic at a time. That does mean, I mean, it's bad because the service, I feel the service doesn't feel quite so good, because if you turn up early, we say, please, can you sit in your car? We don't give you a cup of tea. You have to sit in one chair that we wash down. We don't use the sofas and things like that. So there are, you know, elements of the service which I feel I would prefer to give a better service, and obviously shake your hand and say, how you doing? So, you know, we are limited in that. But in terms of the spread of the coronavirus, it's significantly safer, and it's actually a very safe environment because we can distance ourselves and, as I say, have only one person in at a time. And so for that reason, during this lockdown, medical clinics are remaining open. So we are remaining open as we are a medical clinic. We don't really do any non-surgical work. It's all surgical work, and elective surgical work is still progressing. What I'm talking about here is I am talking as of 7 on the 5th of January. Full disclosure, you know, things could change in the next hour, in the next day, in the next week, in the next month. I don't know how things are going to change. I don't know how things are going to progress. And I think we all know that things can change very quickly. But at the moment, medical clinics are maintaining still open. Having said that, we are doing as much as we can remotely. So we have got video consultations set up. We can share slides. I can go through before and after photos with you. You can send us a photo if you want a comment or an opinion on it. If you don't feel comfortable with video consultations, we can obviously do phone consultations. So we have embraced that, and we have been doing that quite a lot already. A lot of the measures we're already doing. So we are doing what we can in a virtual way, and the advice is that we should work from home if we are able to work from home. So I am able to work from home to an extent, but I can't work from home completely because I do have to see and treat patients. So therefore I will still have clinics. This clinics will still be going on for people who need to be examined, who need to be seen. Treatments are still going on in terms of surgery. And if you have any problems or any issues or any concerns, you can certainly come back to the clinic and we will see you, and that is all fine. What we don't want is for people to stay at home with a problem and think they can't come. So please do get in touch with us if you are worried about anything, or if you have any questions, please do get in touch or ask me here or whatever, the main thing, or one of the main issues that we have, is that we don't want to burden the NHS. So we have to be very aware of that. And I think one of the questions I've got today is about quite a big operation someone wants. So we've got to be very aware that we do not want to burden the NHS. So we don't, particularly ITU, we don't want to do anything that could require an inter-hospital transfer into ITU. I've never had an inter-hospital transfer into ITU, you can safely say, but still it's a thing that can happen. So we need to be careful and be aware of the sort of operations that we're doing to try and reduce the risk of that, because we certainly don't want to be making more work for the NHS. But at the same time, we want to try and keep the wheels moving. If people have got things that they're concerned about, things that they're worried about, then they can still get in touch. We will do what we can in a virtual world. And if you need to come to clinic, if you need to be examined, if you need to be seen, then we are able to see you, because we have quite stringent precautions in place and measures in place to make it safe for us and for you, because we don't want to expose ourselves in any more than you want to expose yourself. So a bit wrong, expose myself, you know what I meant. So yeah, that's where we are. So we're hoping it's the final lockdown. So yes, we're hoping it's the final lockdown, and we're going to get through this, and we're going to do what we can, and we are doing what we can. So that's that. Come back at me if you want. Donna's right back at me. Donna's got a question. Donna's got slight lymphedema in my forearm, 4 months post-op brachioplasty. Aaron, any recommendations to help, please? Also, part 2, and your recommendation for scars, please. 4 months post-op brachioplasty, 360-degree body lift and lipo. Wow, they're starting to stretch slightly. Upper arms very slightly hypertrophic, not bothered by them as much, better than pre-op. Thank you. Donna, okay. Liking your Christmas jumper on the on your picture. She's on Facebook, Instagram. She's got little Christmas jumpers, his and hers. Liking that, very much classy. So first thing, Donna, are you my patient? I said I don't recognize your name, but I don't think you are my patient. So if I would say talk to your surgeon is my first disclosure, because I always feel a bit uncomfortable talking about things 4 months post-op, because that's still in the sort of I would still call that the early post-op period, Donna. And so you really need to talk to your surgeon about what the recommendation is in terms of scar management, and particularly if you're developing hypertrophic scars. But I can talk in general terms for general people, and don't take this as advice specifically for you. I'm not sure if, well, it might be lymphedema in your arm if there's lymph nodes have been involved during the brachioplasty, but it may just be edema of your arm. Lymphedema is a specific condition which can be quite problematic and can be quite difficult to treat. So this is why you need to really talk to your surgeon and get an angle on whether it is lymphedema or just a bit of edema. If it's edema, then elevating your arm can be good. Obviously that's best, but it's not great, isn't it, watching telly like that? But maybe like that, just trying to keep it above the level of your heart. Keep it when you're sitting down, keep your arm on your shoulder. When you're lying in bed at night, maybe resting on your chest. Keeping it above the sort of vertical level of your heart can help with swelling. If it's lymphedema, then there are things that can be done. The compression stockings can be used. Manual drainage, massage can help. And you have got to be a little bit careful in terms of infections, etc. In terms of the hypertrophic scars, 4 months is quite early days, but it's something to watch. Things like silicone gel, silicone sheets. If they are a problem, then you could move on to things like steroid injections, could be thought of. But I think probably in my first instance, I'm thinking elevate, possibly compression. Although you've got to be careful with compression because it's got to end somewhere, and I'm not sure what sort of scarring. Usually scarring goes up into the armpit, so it normally has to, you can't sort of it's hard to get compression across the shoulder, so that can be an issue. Compression can be an issue. and maybe lymphatic massaging if it is thought to be lymphedema, and there are specialists in lymphedema who specialist nurses and people who work within lymphedema if that is looking like what you're getting. But I suspect, to be honest with you, Donna, 4 months post-op, it's probably just a bit of edema, a bit of swelling, which is normal after surgery, particularly with an extremity, with a limb. Angela, good evening. And Donna's back at me. Go, Donna, go. Thank you. He's given me advice with drainage and compression. Just appreciate advice from others too. Had a physical check and been confirmed slightly lymphedema by an endocrine breast plastic surgeon. There you go. Look at that. We've got it there. So, so there you go, Donna. Good. Okay. Well, there you go. Yeah. Drainage. Drainage meaning manual drainage. I'm assuming you mean, Donna. And compression. Yes. Good. Yeah. There you go. So I hope we're on the same page on that one, Donna. Good luck. With that, what we got going on, we got Rosalina on Instagram wanting a breast lift. Oh, God, get this off because it's confusing. Wanting a breast lift. Unsure whether to get just a lift or add implants. Think they might still be droopy with just a lift. Is it best to get a lift and then always get implants later on? Good question, Rosalina. That's a good question, team, from Rosalina. Tricky. That's a tricky one. I would say, Rosalina, if you want a breast lift, if you've got a problem with your breast, the shape of your breast, a breast lift is the best way to treat that, and a breast lift is the way to go. My advice, and everyone's different on this, which means that there's no right or wrong answers, and it's people's opinion. At the end of the day, it's your opinion that matters, to be honest with you. My sort of angle on it is that if it's just the shape you don't like and you're okay with the size, I would say to you, don't have implants, just have a lift. Now, having said that, what I do and what I would do is I would show you photos of what can be achieved with a lift. Because when you have a lift, the breasts are like that, and then they settle. And some people look and think, oh, I'm not sure I'm happy with them settling. I want them to be a bit fuller. And I'm like, well, actually, if you want them fuller, that what I would call sustained upper pole fullness can only be achieved with implants. So if you do want them fuller, then implants will make them fuller. But implants carry with them complications and potentials and risks, and implants will make them bigger. So if you don't want them bigger, I'd be like, well, I'm not sure if I'd have implants just because you want the shape to be fuller. I would maybe see how you go and see if you're happy with the shape, because obviously you can wear a bra and things like that. If you want them bigger, that's a different question. So if your breasts are a bit droopy and you want them lifted and bigger, then I think implants, then okay, then fair enough, implants. You know, you're probably not going to be happy if you don't have implants, because you're going to be about the same size if you don't have implants. But if you're happy with the size, it's a difficult group of patients who, not a difficult group of patients, but it's a discussion to have. If it's droopy and you're happy with the size, you have to be happy with the shape that can be achieved with a lift, because it isn't as full as what can be achieved with implants. If you want that sustained fullness in the upper pole, then implants really do give that sustained fullness. Now, having said all of that, there's a lot of surgeons who don't do a lift and implants together. They would routinely stage it. So if you're not sure and you think, I'm not sure, it's perfectly reasonable to just have the lift and see what you think. You might be happy with the shape of the lift and then happy days. If you're not, you could always have implants later, and that actually, in terms of the risks, the complications, would actually be a safer way of doing it, to actually stage it, to do the lift first and see if you're happy. Now, having said that, it's a little bit more expensive if you do it, stage it, and also obviously it's 2 operations, 2 times off work, 2 times of recovery, etc. So a lot of people do want it in one operation. I do offer it in one operation, but I warn people it has got a high complication rate, a high risk, chance of risks. High chance of risks. It's not right, is it? High risk, high chance of complications. High chance of risks. Anyway, yeah. So it has got a high complication rate with a lift with implants. But in people who are unhappy with the shape and the size, it's the best way to do it. But if it's just shape, I think there's a lot to be said for just going for a lift and seeing if you're happy with the shape. And you send here super droopy breasts, 9 stone weight loss. Go girl, well done. No volume in upper breast. Don't really want bigger, just normal shape. In that case, Rosalina, my feeling and my I'm edging just from what you're saying is to have a lift on its own, see how you go. But you have to be comfortable with the shape that it gives, because what we don't want to do is spend loads of money on a lift, the shape settles and you think, hold on a minute, what's going on here? I wanted them up there. You know, they were up there initially and now they're not up there anymore. You have to be, you know, you have to be aware that's going to happen pre-op, because we don't want to get any surprises post-op, because then you might rightfully be a bit cheesed off. So we don't want that. We don't want cheesed off. So it would be something that we would, or, you know, I would talk to you about. So yeah, you're welcome, Rosalina. There you go. Donna says, thank you. Thank you. Ida says, good evening. Good evening, Ida. So Finch is in the house. Look at that. Going great guns so far. Thank you for that, Donna. And thank you for that, Rosalina. I've got a question here. Is it more common for capsular contracture to happen after exchanging implants? Yes, it absolutely is. And that is the reason why, if someone comes to me with a capsular contracture, I would always say to them, leave it as long as they can, because if you change your implants, you're going to get another capsular contracture. Capsular contracture is just scar tissue forming around the implant, which makes it feel hard. That's what a capsular contracture is. It's not the implant going hard, it's the scar tissue. It's your body forming scar tissue around the implant, contracting around that implant, making it feel hard. And when we do surgery, we create more scar tissue. Doesn't matter who you are, doesn't matter what sort of surgeon, you know, any surgeon, when they let us at a patient and we're going to create scar tissue, that's all we do. So obviously we can remove the old scar tissue and put new implants in, but that's going to create, that's more traumatic operation than the first operation when you had them put in. So a capsular contracture comes quicker second time around. So if you have a bit of a capsule and you think, oh, I don't really like it, it's got a bit hard, so can I have them changed? I'll be like, well, actually, the longer you leave it, the better, because if I change them now, you know, if you've only had them 5 or 6 years or whatever, change them now. What happens if you get another capsular contracture in 3 or 4 years? If you can, the longer you leave it, the better, because then you start the clock ticking later on. So yes, it does come quicker after exchange. Simple answer. So leave it as long as you can, folks, is my advice to you. Evo 1. In fact, that's long underscore Evo, long underscore 1. Nice handle, Evo. Hi, my partner's ears have split from wearing heavy earrings. She has had repaired once before. Is it possible to repair for a second time? I want to repair my ears for a second time. Yes, it is, Evo 1. It's possible to repair for a second time. And that is the problem. When the ears have split, when you repair them, it's always going to be weaker than it was before, than normal skin. So there's 2 ways I would do it. One way is just to repair the hole, or you know, close up the hole or close up the split, and then get them pierced elsewhere on the lobe. Get them pierced either side of the scar, because if you get them pierced near the scar tissue is weaker than normal skin, and so it can easily pull through again. There is a way to repair them keeping the original hole by supporting the hole with 2 flaps of skin to support it, and then you do keep the same hole, but it's a little bit more of a bigger operation. Oh, my English is terrible. A little bit more of a bigger operation. God, did I say that? Looking at the transcript tonight, it's going to be a shocker. I have to edit it. It's a little bit of a bigger operation when you keep the hole. And so if you, I'm not sure, did she have it just repaired and then have it pierced near the scar? So probably the easiest is to have it repaired and then get your ear pierced elsewhere from the, you know, away from the scar, somewhere else on the lobe. But absolutely fine to have it repaired a second time. But the problem is, you know, you can have more scar tissue. So you have got to be careful with heavy earrings. You know, if it has split once, even though you have it repaired, it's going to be weaker. So you have got to be careful with heavy earrings, because you are at a high risk of it putting through again. So that is something to be aware of. Oh, we've got emojis going on in Instagram. That's good. Now, Liz, first up, Liz, can I just point out, everyone, Liz has used the appropriate hashtag AskJJ. I don't know if anyone's aware, but that is the hashtag we are looking to set trending on a Tuesday night. AskJJ. I think we're pretty close. You know, I think we've got low single figures. You know, low single figures of people using the hashtag, but still. Hashtag AskJJ, how can I reduce the chances of infection when having a breast uplift? I keep seeing it described as at the T-junction, and I almost feel it's inevitable. Yep, that's a fair point, Liz. And I won't say it's inevitable, but I would say it's common. It is common, no question. It is common to get infection at the T-junction. Liz, the problem is, well, two things. I'll take in general terms about why you get it, and then I'll talk about how you would reduce your risk of getting it. So you get it because it is the tightest point. It's the tightest point of a lift. It's that T-junction is the tightest point, and so if you're gonna get a wound breakdown, if you're gonna get infection anywhere, that's where you're gonna get it. So it's not uncommon to get it at that T-junction, and a lot of plastic surgery, or at least a lot of body contouring surgery or maybe not liposuction. Anyway, a lot of body contouring surgery is closing things tight, because you want things to be tight. When you do a lift, you want it to be tight. So you could say, well, how do we as surgeons reduce the risk of wound breakdown? Well, we close it less tight, but then you're going to get less of a lift. So we've got to get the balance right. We want to give you a good lift. We want to make the skin tight. Same with a tummy tuck, same with a facelift, same with an arm reduction. You want to make it tight because that's the point of doing the surgery. But at the same time, we don't want the wound to break down. So we've got to get that balance right. And so that's why you often get a wound breakdown there, because we want to close it tight, because we want to give you a tight breast, because that's the point of a breast lift. Now, how can you reduce the risk of infection? Well, surgically we can try and get it right, but as I say, we always trying to make it perfect. But if you do too little, you still have a bit of a droop, and if you do too much, you get a wound breakdown. And much as we always try and get it perfect, there's a chance that it might not be perfect, and I would always try and make it as tight as I can, to be honest with you. And so there is a risk that you might get some breakdown there. People often call it infection. Usually it's just a little bit of breakdown. It's usually a bit red and a bit angry, so it doesn't really get overtly affected. It's just a bit of a nuisance, so you might need dressings for a bit longer. That's the usual. If you're going to get a problem, that's often the case. You just get a dressing down there, which is a nuisance. But once the scar's settled, once the breasts are settled, the scar's hidden up in the fold, so it's actually not a disaster, because the scar is often hidden. It might be a bit thicker than we would have liked, but it's hidden up in the fold, and it's at the cost of getting a better lift. So what can you do to reduce it? So as I say, there's surgical factors and there's patient factors. If your weight is right, it'll be better. So if you're overweight, you have increased risk of wound healing problems. If you smoke, it's a disaster, Liz. So if you're a smoke, I would just forget it. I just wouldn't even have a lift if you smoke. So for goodness sake, don't smoke. And just be positive, good diet, fresh fruit and veg, eat healthily, positive attitude, and try not to worry about it too much. As I say, you might get a little bit of breakdown there, but usually it's just treated with dressings for a few days, maybe a couple of weeks, but it's at the cost of getting a better lift. But it's not inevitable, but it can happen. Jane, that answered my question. Did you ask a question, Jane? Or did something I've already said ask a question? Anyway, right, Olivia, we're coming in thick and fast. We've got Instagram and we've got Facebook. Look at that. Olivia, evening, JJ. Hope you are well. I'm mega concerned. Due to have an ultrasound on my stomach on Thursday, my surgeon said it's not a seroma, but does not know what's happening. I'm frightened. It's like the center of my stomach is hard and raised. Prolapse, fibrosis. Wow. Okay. So, Olivia, you've had a tummy tuck when? Relatively recently, I think. So yeah, I mean, Olivia, this is a problem. I think if you have got a problem relatively soon after your surgery, in the first few months after your surgery, it really is your surgeon who is best placed to help you with this. It's hard for me. I didn't do your surgery. I don't really know what has been done. I haven't examined you. It's good you've seen them. They're arranging an ultrasound, which is great. I don't know what to say. I mean, prolapse is usually not, this is not prolapse. Prolapse is usually downstairs. Fibrosis is just scar tissue. So yeah, maybe it's scar tissue. I don't know how long since your surgery. By prolapse, I think you mean hernia. So it could be hernia. That's a possibility. But it's difficult, Olivia. It's difficult. It's difficult for me. I'm in a difficult position here, because if someone's immediately post-op, they really need to work with their surgeon rather than someone else. It's not right. If it was my patient and they went and asked some other chap or some other person, you know, I'd be like, well, and then they came back to me and said, well, so and so said this. I'm like, well, you know, you're my patient. I've done the surgery. I know what's going on. I'm organising the investigations. I'm organising the tests, and I will look after you. So I think that's really where I would be going, Olivia. And it's good that they've seen you. It looks like they're taking you seriously. They're doing a test, an ultrasound. So just go with it, Olivia, and good luck with that. And you've used the Ask JJ hashtag. Well done. Bit of an afterthought, but hey, you know, and you got it the right way around. So it's not all bad. So that's good. What is going on Instagram? Instagram's going bonkers. Where are we up to? I've got a wave. Evo, that's great. Your clinic is calling me back tomorrow. Awesome, Evo. I hope they're helpful. Are breast implants not a good idea for someone with lupus? No, I wouldn't say that at all, Nikki. The main question I'd have, Nikki, is are you on medication for your lupus? So if you're on medication that might reduce your sort of immunity, you might have an increased risk of infection, and infection is a big deal with implants. We do worry a lot about infection with implants. So if you are on a medication, that might be a thing. If your lupus is severe, then what we would probably do is talk to the doctor who's looking after your lupus to say, look, is it optimized? Is there anything we can do to make the lupus less of a problem, less of a flare-up? If not, if it is optimized, then we'd have a discussion with you as to, as I say, if there was an increased risk of infection, then that's a conversation we'd have to have. But we'd probably talk to you with your doctor looking after your lupus to get advice on that. Kim, hi, asked JJ, could you explain what splitting stitch is, please? Hope I've said that right. Why doesn't happen? Doesn't your body need these stitches? Oh, spitting, I think you mean. Why does it happen? I tried to say. I think you mean spitting, yeah, Kim. So that's usually in surgery like tummy tucks, breast reduction, not so much augmentation. Big wounds. When you do a tummy tuck, when you do a breast reduction, big areas have to be closed under tension. And in order to close the tension, what we do is we use deep sutures to take the tension off the wound before we put our skin suture in. And if you look back at one of my videos, I've got a video on YouTube, which, by the way, I've got 1,000 subscribers on YouTube. You heard me, 1,000 subscribers on YouTube. If ever there was a doubt that this guy was a social media influencer, I think we can all agree that he's arrived. 1,000. We got 1,000 subscribers on YouTube. So anyway, so there is a thank you. So there is a video on YouTube where someone said, "What's the how long does dissolvable sutures take to dissolve?" And I ramble on. Apparently, a lot of people have commented saying he's rambling on about it, because the answer is there's lots of different types of dissolvable sutures. So when you're doing something like a tummy tuck or a breast reduction, you use long-term dissolving sutures deep, and then you put a dissolving suture in the skin, which is a shorter-term dissolving suture. So the one in the skin dissolves more quickly than the one deep. Now, sometimes if a suture is in your body for a long time, your body gets cheesed off, particularly the knot. They'll say, oh, the suture takes 3 months to dissolve or 6 weeks to dissolve or something, but they're talking about the suture there because it's surrounded by water. When you have a knot, the outside's only surrounded by water, so the outside will dissolve, but the inside will take longer to dissolve. So if it takes a long time to dissolve, it'll get to the stage where your body will say, I've had enough of this, you're out, mate. And it spits out the foreign body. The suture is basically a foreign body, and it spits it out. And so you can get little localized areas with breast, say classically breast reductions, tummy tucks are the sort of classics, where you get little bits of this suture. It's a dissolvable suture, usually a vicryl. It's a braided suture. Braided means it's sort of like a shoelace, as opposed to a monofilament, which is like a fishing line. And so there's more. So the suture takes a long time to dissolve, and your body's and it spits out. And you're absolutely right. It doesn't need. It's usually some months after surgery, so usually the wound is pretty well healed. So you don't actually need it for the integrity. It's not a worry that the wound's going to break down, but it's just not very nice because people think, oh, I've got an infection, I've got all this pus coming out and stuff like that. Because there's usually a little bit of yellow stuff, which actually is pus, but it's usually not a systemic infection. It's just a localized infection around the suture, and once the suture comes out, it settles. So it can be a bit of a nuisance, but that's what it is. Now I've got it. Anne Redmore sent a request to be in my live video. Now, in my experience, Anne, that is a mistake of people not actually wanting to be in my video. But you know, I can go live with you, Anne, if you want me to. But I'm assuming it's a mistake, because if I press the button, I'll end up in your living room, and all the viewers at home will be able to see you in your living room just like they can see me. So I don't know if you're ready for that sort of attention, and because you know it weighs heavy on your shoulders when you have this many people depending on you. What's going on? Olivia is mega concerned. We've done that one. Ask JJ. Good. Yes, Olivia. It's very hard. It's very hard if my surgeon isn't telling me anything. I had to organise my own ultrasound. Oh, right. Okay. Well, Olivia, yes, it is hard. And I think this is why prior to surgery, a lot of people will say, what implant shall I have? Shall I have a textured one, or a polyurethane, or the smooth, or shall I have a high profile, or a this one? Or shall I have a fleur-de-lis tummy tuck, or shall I have a 360, or should I have a this, or a mini, or a what stitch, or should I use a dissolvable stitch, or a locking stitch, or should I use the glue, or should I use drain? What people get into all this stuff about the surgery, and I'll always say to you, most important thing is choosing the surgeon. That's the most important thing. You've got to choose a surgeon, look for someone who's going to look after you, look for someone you get on with, because it is very important when you have issues like this. And, you know, that is the thing you've got to look for, because to be quite frank with you, it is not going to make a huge amount of difference whether you have a glue or drains or locking stitches or polyurethane or smooth or fleur-de-lis or a full or whatever. You know, you can see 10 surgeons and they'll give you different opinions as to the type of surgery you have, the type of implant, the type of this. It doesn't matter they're wrong or right. It just means we've all got our own opinions, we've all got our own experiences, and we give you our opinion as to what we think might work well. And it's really the surgeon you've got to look for, rather than actually, I wouldn't worry. People these days get really on the internet and they're like, oh, should I have a PDS to close the wound, or would you use a monocryl? Or, you know, getting into these new minutiae. Shall I have the 275 high profile or the 315 high profile, or the this or that? They get into minutiae of stuff. And I'm like, well, yeah, you could. I'm not saying it doesn't matter, but it doesn't matter that much. And yet people worry about it so much, and yet they don't worry so much about the surgeon that they choose. Then they're like, you know, they don't really do that much research on the surgeon. I think, oh God, they think, so I think that's where the focus should be, personally, rather than worrying too much about, you know, different techniques, etc. That's where I am anyway. That's my view. What is going on Instagram? What's everyone laughing at? Why is everyone laughing on Instagram? I missed something. And it was a mistake. Good. Okay. What? Sabotage 80. Sabotage. It's a good name, isn't it? With an A, not an O. With a breast reduction or lift, how do you take the weight / tension of the breast skin tissue? I.e., do you stitch the internal breast tissue? Hope that makes sense. It does make sense. And that's a good question, Sabotage, because that is one of the issues. And that is one of the reasons why it sort of settles, because you're absolutely right. There is tension there. And very good question, Sabotage. And that is something that we're working, and people are trying to fix and trying to do things to support the breast, so that the weight of the breast isn't on the skin. Because if the weight is on the skin, it's going to droop again. And that's why it settles. I'm not going to say droop, but it does settle. And in my practice, I think the best thing is to take some volume out. So if anything, if someone's got a bigger breast and they're saying, look, I'm happy with the size, I just want to make the shape better, I'd sometimes say, actually, you know what, if you've got a bigger breast, if you've got like an E, F, G cup, something like that, I'm like, well, actually, if we took some volume out of particularly out of the lower pole, that would put less tension, so less likely to droop. That's the best way to stop it from drooping. There are things you can do to anchor the breast tissue up to the rib cage, and there are prosthetic meshes you can put in, these so-called internal bras that will take the tension off, to do just that, to try and give a more sustained fullness in the upper pole and a more long-lasting result. But they've got their own issues. I personally don't use them. I think the concept is sound. I think the concept is good. I think they are addressing a problem that exists. I don't particularly use them because I think they've all got their own issues. So I don't, weigh up the pros and cons, and I don't feel comfortable using them personally, but there are people out there who probably do use them. So, you know, again, no right or wrong. But yes, it is a part of a breast reduction or a lift. And what you do technically, as far as a surgeon goes, is you mobilize the tissue as much as you can, and you move the tissue up north. So you have to mobilize it quite a lot. It's not just removing skin. You're actually mobilizing the breast quite a lot to move it up north to try and reshape the breast, and that is the actual surgery of a breast reduction or breast lift. But it is an issue having the weight on there. And that is a good question, Sabotage. Well done, you. Nikki TW79. I was wanting tummy tuck with some lipo and breast surgery. Would it be better to have surgeries together or separately? Also, I am on the hydroxyquinone for the lupus. Now, that is funny that you say that, because someone else has asked a question here. Here we go. It's probably you, isn't it? I'm looking. Actually, no, it's a different. Well, Nikki TW79, thank you for that question. We've got one here. Would it be better to have surgery separately, or would you have surgeries in one go because of your anaesthesia and recovery time? This person says, I'm interested in tummy tuck with lipo and mastopexy augmentation. What are you interested in? Yeah. I'm looking at getting surgery for a tummy tuck with liposuction and possibly breast uplift with implant. I had a hysterectomy 3 years ago with poor care and got a kidney infection and paralytic ileus, which led to twisted bowel, and then developed sepsis. So surgery is daunting to me. All right. Well, that person there, yeah. Well, so I think any surgery would be daunting to you if you've got all those problems. So yeah, you need to think about any surgery. But in general terms, whether to have them together or separately, the hydroxychloroquine for the lupus isn't an issue, I don't think, Nikki. I don't think hydroxychloroquine is going to be an issue, although I would take advice from your doctor who's looking after it, because I'm not an expert in that. So I would take advice on that, but I don't think that'll be a problem. But just in general, talking about, I mean, times have changed, to be honest with you, and tummy tuck with lipo and breast surgery would normally be fine. So-called mummy makeover, pretty routine to do, pretty standard to do. We have been doing some. I have done some of these types of operations, but usually on the lower end of the spectrum. So maybe a tummy tuck without lipo, maybe a breast augmentation. You know, a tummy tuck with lipo and maybe a breast augmentation with implants. That's sort of that's expanding the time out. So we're taking these on a case by case basis because we are limiting the amount of surgery that we can do, and so particularly with the new lockdown, and being very aware that we don't want to put pressure on the NHS and aware of the amount of surgery we do, I think we will be a bit more reluctant to take on bigger operations like these. Not because it's unsafe for you, it's a safe thing to do, and it's something that used to be routinely done back in the day. But I think with all of the COVID issues, we are limiting the surgery time, and we also want to limit the risk of people requiring any help from the NHS, particularly in terms of intensive care. And certainly a longer operation, longer surgery does potentially increase that risk. As I say, it's never happened to me. No one's ever had to have that help. But on paper, it has happened in the world, and it will happen more likely on a longer operation. So I think these joint operations are going to be curbed somewhat during this time until things can get on a more even footing. Once things are on an even footing, we're not so worried about the capacity in the NHS, and we're not so worried about these problems, then certainly it would be possible to do, tummy tuck with lipo and breast surgery at the same time. Although, even though we can do them both at the same time, if we were in a situation where we could, we would have a discussion with you to see what is right for you, because it's quite a big op. It is quite a lot to have both of those done at the same time, and it does knock you back. But it suits some people because they get one period of recovery. But like I was saying about the lifts with implants and the, one period of recovery, one time off work. So it does suit some people, but it is quite a big thing to do. Natty, are you continuing even with the lockdown? Yes, we are, Natty. Although we have got measures in place, we're doing much as we can virtually, and we're taking things on a case-by-case basis in terms of seeing people in clinic. But we are able to see people in clinic. We've got processes in place. So if you've got any questions, any concerns, if you need to be examined, if you need to be seen, you can still be seen. We are open as a medical facility, although no non-surgical procedures. Not that we did any anyway. It's all surgical at the clinic. Evo's back in the house. It's me again. When you repair earlobes, are they just stitched, or is plastic surgery also used? Are they just stitched? Honestly. Are they just... Evo, come on. We don't just stitch anything. Plastic surgery is used 24/7 at my place. That's all we do, plastic surgery. We don't just stitch. What's the matter with you? Just stitch. Good God. No, Evo, it's an art, Evo. Repairing split earlobes, would you believe? I've written a paper on it, and when you write a paper on something, you realise there's hundreds of ways of doing it. Like belly button for the tummy tuck, I've written a paper on that as well. When you go into it, you research it. There's loads of people who've written papers on it. So yeah, the reason is that the worry with repairing earlobes, since you've asked, is that the scar will contract, and particularly if it's a completely split earlobe, you worry that there'll be a notch in the earlobe if the scar contracts, because you want a nice smooth contour for the earlobe. So you have to avoid the scar contracting. And again, there's lots of different ways you can do it. People put in Z-plasties or put in different they'll move the tissue around basically to try and elongate the scar, because you don't want it to contract. So sometimes the earlobe looks a bit elongated afterwards, and then in time when it does contract, it goes to look normal again. But it's you have to use techniques to make it less likely to contract. Contraction is an issue. So yeah, on paper, to the naked eye, it might look like it's just stitched, Evo, but we have to do things when we're stitching it to try and elongate it to reduce the risk of contraction. Sabotage. Would you conduct breast lift and reduction under twilight if one has no health issues but a higher end BMI? Yes. I mean, the main thing about the BMI is you've got to be happy with your weight, comfortable with your weight. If you want to lose weight, it's better to do that first rather than having surgery. Depends what you mean by higher end BMI, I guess. But yeah, that's absolutely fine. Breast lift and reduction can be done under twilight. That would be fine. Blepharoplasty bilateral, upper and lower. Are you doing these? Yes, Maisie May Lose. We are. I say we are. That would be Kurum. Kurum's doing those. Kurum Khan, who works with me at the clinic. I don't do the blepharoplasties. I don't do the faces. But yes, that is still being done at the clinic at the moment. Here we go. I have psoriasis, and I was wondering if that would have any effect on the gynaecomastia procedure. Not really. I mean, I guess if you had active psoriasis in the area of the scars, particularly if there's any risk of infection, if it was quite active, then I think I would be I would postpone surgery until that flare-up had died down. But if there's no psoriasis over the area where you're having the scars, then no, not at all. If there is psoriasis over that area, then I'd want it to be pretty well quiet and pretty well treated before making scars in it, because I would worry about infection. So I think that would be my main concern, whether there be any psoriasis in the area where we're making the scars. But if not, no. And again, a bit like earlier, if you've got significant psoriasis, if you're on immunosuppressants, then that might affect your risk of getting infection, but it's less of a problem than implants, because there's no implants used with the gynaecomastia, so we don't worry. Obviously, we worry about infection, but not quite as much as we would for someone who are using implants. How long would this procedure take? Maisie Mailer. Oh, bilateral, upper and lower. The problem. Well, sorry, Maisie May. Sorry. I've got to revise my answer. Upper blepharoplasty can be done under local anaesthetic. Upper and lower is a different thing. Upper and lower would need an anaesthetic, probably a general anaesthetic for lower. So upper and lower blepharoplasties would take an hour and a half, give or take, maybe 2 hours. You know, it's a bit of a procedure. I say I don't do it myself, but it's a bigger procedure with lower. And so are we still doing these? Again, this is something we'd have to do at the hospital. And at the moment, the hospital is still doing elective planned surgery. So we are still doing elective surgery at the hospitals. Things can change on a sixpence, but at the moment, we are doing elective planned surgery. And it would take, about an hour and a half. And sorry, so upper and lower is a little bit more complicated than just upper. Sabotage. What's the rough waiting time for booking surgery? Month or two, couple of months, I think. Sabotage. I guess it depends what it is. The local anaesthetic cases less will be weeks. General anaesthetic or local sedation would probably be a month, couple of months, month or two, I think. I haven't really got the diary, to be honest, but I think it's something like that. Is it best to wait until post-baby to have my implants removed or delay pregnancy to have them removed first? I'm looking to have implants removed, have had them above tissue for 5 years. I've one child and looking to get pregnant in the next 6 months, sooner if we can. Is it best to wait until post-baby to have them removed or delay baby and have them removed first? Right, so you got implants in and you're looking to have another child. I would say it depends if the implants are causing you a problem. So if the implants are causing you a problem, then I would probably get them out sooner rather than later, because then that gets rid of your problem. But if the implants are not causing you a problem, then I would say that you should, the main thing is whether is the cosmetic outcome from having the implants removed, whether that's an issue or not. So if that's not an issue and you just say, look, I've had enough, don't want them anymore, doesn't matter when you remove them. If you are worried about the cosmetic outcome of having them removed and you're thinking, well, actually, I might have something done like a lift or something like that to improve the shape when having them removed, you would be better off waiting till you've finished your family, because if you have a lift or have anything done at the time of implant removal and then you have a baby, they can droop again and all sorts of things can happen. So obviously, when you have the implants removed, you're going to lose shape and volume in your breasts. You have to accept that whenever you have it done. But if you were thinking of having something like perhaps a lift at the time of the implant removal, I wouldn't do that prior to having a baby. I would say to have your baby first and then have them removed, and then you can maybe decide whether a lift or something will be appropriate. So I guess if they're not causing problems with you, then I wouldn't delay getting pregnant. I would go ahead and have your child and maybe have it later. But if they are causing problems, or if the cosmetic outcome is not an issue to you, there's no reason why you can't have it done now and then go and have children. More children, but it would change the shape of your breasts. Have I done that question? No, I have. We done that question, haven't we? What we got? Thanks, JG. I didn't realize lower would require a general. Lower would require, yes, lower would require a general or local and sedation, but not pure local, Maisie. You couldn't really do low. I don't think so anyway. I'm probably best asking Kura on this, but lower often involves a bit more of a sort of mid facelift and sort of tightening the cheek area, and a little bit more dissection down into this area. Upper is just removing the skin in the upper lid, so it can be done under local anaesthetic. But lower usually needs a bit more anaesthetics. It needs a bit more work and a bit more dissection, because it often contours and tightens the cheek. But yes, thank for Kuram. Are the questions on your site for both? I don't know, but if you put in a sort of inquiry and say I want a price for both, then we can definitely send you a price for both. Or if you give me your email address somehow, can you direct message me or something and just say what's the price for both? I can send you the price for both, or my team, or the team to do it. So it is, Maisie. Get the team. But anyway, but definitely there is a price for both, and so if you get in touch somehow, we'll give you a price for both. Sorry, just going sabotage back in the house. Sorry, just going back to my question with the tissue and breast lift. To clarify, you don't stitch straps, lift the internal breast tissue, bigger breast obs, as you said, you may recommend reduction. Correct. So what you do is what I do. People are different, and some people do use sort of internal flaps and stitch them up high in the breast. But if you're stitching breast to breast, I feel the whole lot's going to droop. So what I do is as you say, obviously if you're taking volume out, great. But if not, I'm just mobilizing the breast, mobilize the breast up north, and then close the skin. And you rely on the skin envelope supporting the breast. I feel that if you try and put a stitch of breast tissue to breast tissue, or breast tissue to the fascia or something, I don't feel it's going to hold. So if you're going to do anything to support, there are prosthetic meshes and supports. They call them internal bras. There's different designs of them where you can put a prosthetic mesh in and then secure it either to the ribs or the periosteum to support it all, which is, if you're going to do anything, that's the thing to do. But I don't put any stitches internally to sort of keep the breast up there. I just rely on mobilizing the breast and using the skin envelope to support the breast. So that's where I am on that. So hope everyone's all right. Hope everyone's coping. Hope that we will all get the vaccine and all be happy and safe once this is all over. Thanks, JJ. I've already had a virtual consultation with you last year during the first lockdown. Would I have to pay for another with the surgeon who does the eyelid? No, you wouldn't, Maisie. Once you've had a consultation, you don't have to pay for the next consultation. It'd be lovely to see you again. Just remind them that you've already had one with me last year, but that would be fine. So no, that'd be nice to see you, or for Krum to see you. So thank you, Beck Simmons 1. TY Sabotage. So I'm going to check out of here, guys. Check out and have a lie down. And actually, yes, Antiques Road Trip. Don't mind if I do. Happy New Year, JJ, and thankful you for another informative Q&A. Jackie, you are a staunch supporter, and as is my private journey. Happy New Year. Happy 2021, guys. I know it's been a bit of a ropey start, but come on, let's be positive, and let's push through. Happy New Year, everybody. I wish I could put something. Can I put something on the screen? Can we get a Happy New Year? What's that? Happy New Year. Happy New Year, you beautiful people. And I'm going to Facebook. I don't know if I can't do it on Facebook. So I'm going to check out. Is anyone still on Facebook? I'm going to check out, guys. And I will see you that same time next week. So, don't be square. Be there, guys. Stop in the stream. Happy New Year to Facebook too. Big up yourselves. Love you big time. Tuesday night, 7 p.m.